Welcome to the Liver Lounge, your go-to podcast for the latest updates in hepatology, featuring discussions with the world's leading experts. We are thrilled to have a distinguished guest with us today, Professor Mazen Noureddin. He is renowned for his pioneering work as the founding director of the Fatty Liver Program at Cedars-Sinai Medical Center and now serves as the director of the cutting-edge Houston Research Institute. With over 40 investigational clinical studies of novel treatments for NASH under his belt, Dr. Noureddin is undeniably one of the foremost authorities on non-alcoholic fatty liver disease. Without further ado, let's dive into fatty liver disease with Dr. Noureddin.
Okay, thank you so much, Prof. So I just want to ask you, how did the change came about from NAFLD to MASLD?
Yeah, I think let's take a little bit history. So the history is, I guess the term was coined in 1980s as by Ludwig Ita. Yeah, and at that time he couldn't get that paper published, something that, to think of. And he sent it to multiple journal, and he ended up with Mayo Proceeding. Not it's a bad journal, it's a great journal, but he tried multiple journals. But he described this phenomena of these patients that they don't drink alcohol, but they look like alcohol, and they end up with steatohepatitis and fibrosis and cirrhosis. And the term was coined as non-alcoholic fatty liver disease and NASH. And throughout the years, they knew it's not the perfect term, and or people kind of discussed it, and there were attempts to change it many years ago, but that was not changed given the development of non-invasive testing, clinical trials, and multiple other factors. And a few years ago, I think now it's 3-4 years ago, there were few people that raised the question, rightfully so, if why we're not considering important things in the disease, such as the metabolic syndrome that is tightly associated with non-alcoholic fatty liver disease called previously. And the other question also came up from patients' perspective. Well, you use the term alcohol in a disease, and when I go tell my neighbor or my friend that I have non-alcoholic, although I say non-alcoholic, they stigmatize me. Sometimes they say, why he's saying non, maybe he is, and all these things, or she is. So there was a paper that came up a few years ago in Gastro and multiple journals that coined the term as MAFLD, but it also changed the definition a little bit to include other etiologies, including alcohol, under the umbrella of NAFLD. That changed to MAFLD. So other efforts started saying, well, that way we're losing a lot of momentum in what we have built in the field in clinical trials, as well as in NITs. So I guess there was a democratic process, Delphi process, that went through multiple rounds that included multiple societies, the American Association for Study of Liver Disease, European Association for Study of Liver Disease, as well as ALA, which is the Latin America. And then multiple societies joined, like the Indian Society, Japanese societies, and many, many, many others. And importantly, it took in consideration what other people are concerned about, the metabolic. It took in consideration also what the patients are concerned about. And at the end of the day, people voted for that process. So it could be you and I that did not say that the final name is MASLD, like when we did the survey. But at the end of the day, there was a high degree of agreement on the term that include metabolic, lift the word alcoholic, and replace it with something more friendly, like it's now MASLD, metabolic dysfunction associated steatotic liver disease. But the big term is, I'll stop here for a second. I'll tell you that what's the umbrella if you wanna talk about it.
Yeah, so I guess the big umbrella would be steatotic liver disease, and
SLD, right?
Right, and that captures everything under the umbrella.
Fatty liver, basically, but we don't tell the patient if you're fatty liver. We call it steatotic liver disease, and then we explain it. And some people say, well, you have to use the word fat anyways. Sure, you can use it. But in different languages, actually, a lot of people say we don't have the word fatty, we have steatotic or something like that. I think the Italians told me that at a certain point. So the big umbrella is steatotic liver disease. Then you have the MASLD, which is the NAFLD, but has metabolic syndrome in it, without the alcohol in it. It mimics the previous definition overall, without much changes for the clinical trials and NITs. Indeed, arguably, actually, a lot of clinical trials are rich, rightfully so, with metabolic syndrome features. So it's being consistent with what has been done. And then the alcohol-related liver disease has two features, as you know. One of them, importantly, is called MASLD, which is this metabolic features and drinking from 30 to 60. But importantly, also, I want to emphasize that they were alcohol-related liver disease experts that have contributed to this process in that nomenclature and the entire process.
Right. So, when NAFLD was first introduced, I think a lot of people said that you lose the lean population, the patients without metabolic dysfunction. If we do, when we change it to MASLD, would that still be a consideration? Because, I know that the definition has more freeway compared to that of MASLD, but will we be losing out the lean NAFLD patients who are kind of independent from metabolic dysfunction, in a way?
And I'm interested in your opinion here. Actually, I've done a lot of studies, right, in the lean NAFLD previously. But also, the metabolic syndrome, you don't have to have obesity as one of them. As you know, a lot of lean NAFLD, they get lean NAFLD because they have other metabolic features. And that's what we found often. They have type 2 diabetes or hypertension or slightly higher waist circumflex or dyslipidemia and all this. So I don't think it misses them. Rather, it's the weight is there, but also they can capture other features that they usually associated with lean NAFLD previously. It captured under this MASLD, a new term. But what do you think now? Like you yourself have led this actually lean mini publication, lean NAFLD. I know you started looking at new data. What's your thoughts on it? What's especially from
I don't know.
the Asian side of the world, because this is very common there.
Yeah,
Tell us what you guys feel.
I think in Asia it might be a bit more pronounced, the effect. I guess in the West, it's quite different. But at least in Asia, people are generally more lean in nature, and they might not have that amount of metabolic dysfunction. Although I do know that the SLD has another arm that captures the patients with steatotic liver disease without metabolic dysfunction. So I guess it still captures it under the umbrella of steatotic liver disease. In terms of clinical trials, however, would the target be on MASLD or will it be on SLD on the broader aspect?
Yeah, don't forget also clinical trials. As of today, we're still heavily relying on the liver biopsy as an outcome for drug approval, and that NASH term was changed to MASH, and the biopsy will capture the steatohepatitis and fibrosis at the current time, no matter what. So if you're working out an Asian patient and let's say he ends up on a biopsy, it will capture steatohepatitis with F2 and F3 or the MASH in this population. So I don't think it will preclude patients from Asia at all. And also a consideration when go and apply for trial regulators. And I know, like in Japan, have their own set of regulations, and this is something that needs to be discussed with the regulator while they're designing the trial.
Right. Okay. How about MASLD? Well, this term, in metabolic, like steatotic liver disease in ALD is pretty new. It's a pretty new concept. What's your view on it?
Yeah, so again, I just want to make sure it's people understand this was brought up by a lot of alcohol-related liver disease experts. And the perfect example that has been brought up, a 50 years old Mexican American who's now it's enriched with all these genotypes, who's overweight, have diabetes, and drinks a moderate amount of alcohol. What is that? So I guess it's a niche area that needs to be explored. The question is, do they have accelerated rate of fibrosis? Do they have, if you treat the metabolic disease, uh, for instance, you can treat the alcohol, which doesn't make sense. But if you think about it this way, um, it can make sense. One example is GLP-1. So if you give a patient GLP-1, such a patient a GLP-1 that I talked to you about, they lose weight, it helps their metabolic feature, but also we have data now on GLP-1 that they crave less alcohol and actually it helps them drinking less. So the question is in such a patient is if they in other trials that could have excluded them because they have a little bit higher amount of alcohol, they now be targeted for therapies such as like this concept that I told you about. So a lot of interesting, funky, provocative ideas that needs to be explored. Again, I don't think it came from people with non-alcoholic fatty liver disease previously expertise, now MASLD experts. Rather, it was brought up by a lot of in the room in Chicago that these were examples that were brought up by a lot of alcohol-related liver disease experts.
It's pretty much opened up a new field to actually study in. Yeah, and it's quite interesting that the spectrum can be so different between the two, and how alcohol can affect your liver so much in a way that we don't appreciate sometimes, I guess, in a sense whereby we omit the fact that they are not considered NAFLD just because they drank alcohol, and therefore we don't treat the metabolic dysfunction. And now we're trying to include them under the umbrella term, and that helps to bring together everything. I think that's wonderful. Moving from there, however, where would the current research be headed towards for MASLD or steatotic liver disease?
Yeah, I mean, with MASL, I think one big concept is we have not lost momentum. There are data coming from many consortiums such as Litmus and Nimble emphasizing the fact that this population MASL look like very much like the NAFLD. So we have not lost momentum in terms of NITs, the cutoffs and all this. And the clinical trials are not much change. Indeed, if you actually look at an example of the Mastro-Nash, the resmetirom data that was presented recently in the, I think it was EASL or ASLD, I'm mixing EASL. I was just EASL. And we presented it there. And if you look at the population there, and this will be probably the first phase 3 drug approved drug, actually the population looks like MASL completely. So we have not lost momentum in terms of drug development or NITs. I think we have to look at subtle differences. I think this is the right population to study. And although the debate and people had differences and there were a lot of papers going back and forth, at the end of the day, to consider metabolic syndrome, this newer process consider metabolic syndrome. So it moved at least one direction of where everyone wanted it to go, which is addressing the body at all, and not disconnected from the metabolic syndrome, although we didn't do much previously. But also going back to MetALD that the alcohol colleagues, they talked about, we were in the NAFL field, we're kind of a little bit slightly ignorant, and we did not it's unintentionally. And I mean, an example, that JHEP paper that came out and had the PEth test positive in a lot of NAFL patients, well, they don't heavily they're not heavy drinker. Maybe they were drinking a bit more than they tell us, but yet we don't know if it's affecting them or not. So that now, like, I guess what we should discover or we should understand if these group that the PET positive is belonging to MASLD. Of course, there will be people like they told you they're not drinking and they're drinking so much, but if it's like it's PET positive and they're drinking that moderate amount, so a lot to talk about, a lot to discover, and I think it brings an opportunity. Indeed, I can argue that it can bring more opportunities for developing therapies in population. People were worried about, or sponsors were worried about, including the alcohol-related liver disease, because it could be that they probably thought the patients have an addiction to something that will affect their drug therapy. But here, those are a little bit slightly higher amount than usual that could be targeted. For as an example I gave you, and it opens probably the door for more population to be looked into that otherwise would have been excluded from other trials. And I heard that actually often in many European countries it was like, well, this amount is, I have patients drinking more than an amount, I cannot include him, but he's really, really drinking like our standards in this country or what's common in this country. So you see, like, those are huge areas of questions that needs to be looked at.
Right. Actually, how would like we use arbitrary limit to say what is considered significant alcohol use, but if we move the thing left or right, they could significantly affect how we define the population. I think that's where NAFLD was, a lot of criticism was found, but at least in now MASLD and steatotic liver disease, at least we can actually capture the entire spectrum, regardless, under the umbrella of steatotic liver disease.
Right. I totally agree. And don't forget the other part of the tree. Like it's acknowledging that Hep B and Hep C could come steatotic liver disease. Well, arguing now hepatitis C is eradicated, but hepatitis B, you have hepatitis B and steatotic liver disease. This is a whole entity that people are getting larger and larger. People are having more diabetes. There was a recent paper, which is a very important paper I need you to pay attention to. There was a recent paper published in The Lancet that talked about the projection of type 2 diabetes in 2050. So this is our highest impact factor journal, or top 2 clinically, and showing data on the projection of type 2 diabetes. It's 1.3 billion people in 2050. So despite all the buzz about the new GLP-1s, duals and triples, and they can reduce weight by 25% and all this, the projection is going up. And many of these drugs will plateau at a certain point or be untolerated. Sure, they will help a lot of people, but unfortunately, the problem is just going to increase, and we have to pay attention to it from the liver standpoint because it's directly affected by it. People are drinking more and eating more, and we need better details on each phenomena and their overlap as well.
Okay, thank you so much, Prof. I think thanks for your time on this.
We have come to the end of the episode. Thank you for joining us, and stay tuned for more captivating discussions.